how relevant are skeletal-related events to castration-resistant prostate cancer? You know, a lot has been made of this endpoint of skeletal-related events or symptomatic skeletal events in clinical trials around prostate cancer. The fact of the matter is, this is really critical to patients, and it's probably an area that is underappreciated by clinicians. There's really only two things that matter to our patients with metastatic castration-resistant prostate cancer, and that's how long they're going to live and their quality of life. And for patients that have a significant tumor burden of bone metastasis, skeletal events, whether those are the skeletal-related events defined in, say, the denosumab or the zoledronic acid trials, or the symptomatic skeletal events defined in the Alcimta trial with radium, these are really important clinical sort of life-changing events. Things like the need for external beam radiation, significant bone pain, cord compression, pathologic fractures. These things, even when we treat them, the patients are really never quite the same. So to me, these are really important events, not just to treat, but to prevent whenever we can. So radium-223 and denosumab were not studied in the Alcimta trial, frankly, because in Europe, the denosumab agent wasn't widely available. So to some extent, we are extrapolating in our clinical practice now that the use of zoledronic acid with radium-223 was used in that trial and actually was tolerated quite well. In fact, there's some trend towards even a better clinical outcome in terms of skeletal events for patients who got both agents. And to me, I'm comfortable extrapolating that data to denosumab and radium. And in our experience, and we've probably treated now about 40 patients with radium-223, the vast majority of those patients have been on denosumab or were previously treated with denosumab, and we've really seen no significant bony complications associated with that combination. So Oncotype DX is it's a fascinating new technology. You know, for probably the last, now 30 years, we've been using the Gleason score and as our main pathologic tool for grading cancer and deciding on the aggressiveness of the disease and how best to manage patients. And it's served us well. I mean, we probably get 80% of our patients right when we do transrectal biopsies and we look at the biopsy tissue and we form a Gleason score. But it's not perfect. And there's a good 20–25% of patients who have a different Gleason score and perhaps a very different clinical outcome when we do surgery on those patients and we get a pathologic staging. To know from a biopsy what that real pathologic staging is from a surgical specimen before you commit somebody to surgery would be fantastic, because we're in a situation now where I think we recognize in prostate cancer there's a group of patients that probably don't need surgery, can certainly be delayed, and maybe don't need it at all. And instead, what we'd like to do is offer those patients active surveillance. To do that, to do active surveillance, particularly in a young guy with prostate cancer who's got a life expectancy of 15 or 20 years, it makes us nervous, because even a slow-growing cancer that's a little bit more aggressive than the average, could be life-threatening down the road. So having the tools to best really understand what the risk is for that patient in terms of their pathologic stage and ultimately their risk of progression is critical. Oncotype DX really is a step in that direction. It allows us to have an independent sort of assessment at the RNA level, looking at all the genes that are expressed in that tumor and focusing on this particular set of genes that have been tested now and validated and shown to really correlate with those patients who are at increased risk, not guaranteed, but at increased risk of having an upgrade of their tumor. And that's important, because just going from a Gleason 6 to a Gleason 7 completely changes our comfort level with active surveillance. If someone's got a Gleason 7 cancer, there are now large randomized studies showing a real survival advantage associated with radical prostatectomy versus deferred therapy. So to me, knowing that somebody is at increased risk for an upgrade of their Gleason cancer is really critical. Unfortunately, at Duke, we haven't had this test formulary because our formulation committee has said, look, that has to be published. Well, it's published now. So we're taking it back to our committee. We would, at least at Duke, like to have all the tools available, including Oncotype DX. There's probably going to be more tools than this available, some already and others to come. And I think that the more and the competition we have there and the opportunity to optimize this is great. But really, I think we're in a new era now of prostate cancer. Gleason score alone is no longer going to be completely sufficient for us to risk stratify patients. We're going to want to use these tools as well. So here at ASCO in 2014, there's a number of emerging therapies that are being tested right now in prostate cancer. And we're very excited that despite the fact that we have had this great run of 5 new drugs FDA approved for prostate cancer, we are very likely to have more. They range in their mechanism from cabozantinib, a multi-targeted TKI that blocks both VEGF and c-Met, is being tested as completed phase 3 testing. We're waiting on these results. There's a number of phase 1 and phase 2 studies being reported out here with this agent. It's got broad activity in a number of solid tumors, and in prostate cancer in particular has shown some remarkable effects on pain and on bone scan changes. So we're excited to see those results come out later this year, early next year for that phase 3 study. There's a number of immunotherapies that are being developed now in a number of cancers, and I think in prostate cancer, we're very interested in a couple of these. Prostavax is under development, should be completing its accrual soon, and we look forward to those results. Clearly, sipuleucel T has shown that increasing antigen-presenting cells, increasing the T-cell recognition of prostate cancer can be associated with a real survival advantage. And using something like Prostavax that can perhaps more efficiently or more easily deliver that to a broader patient population is a great step forward as well. In addition, I think ipilimumab has shown some real promise. It's not necessarily had a definitive positive phase 3 study yet, but there are subgroups that are clearly benefiting from the use of CTLA-4 inhibition. So we look forward to more studies with that agent and that class of checkpoint inhibitors as well for prostate cancer.